So welcome to Orlando Live Endoscopy webinar. So this morning, this is a breakfast session for those of you interested in EUS-guided tissue acquisition. So what I have put together is a series of videos and lecture that will cover everything that is relevant to EUS in the present year. And then we have about 20 to 25 minutes of educational material that will be video cast, following which we will have live demonstrations starting at 8 a.m. this morning. So I would like to thank Medtronic for whom we are going to be conducting this program for their sponsorship, and thanks to everyone for joining us this morning. So my objectives for this talk are threefold. One, I want to talk about the best needle for tissue acquisition, whether it is an FNA needle or a FNB needle. And then I want to talk to you about sampling maneuvers. There are multiple techniques for getting good tissue samples. So we will discuss on what evidence shows for which maneuver is the best. And finally, I will talk to you about the best methods that we can process the tissue once it is obtained. So if you are looking at fine needle aspiration, to my knowledge, this was probably the last study, and since then everything became about fine needle biopsies. So this was a randomized trial that we conducted in 2018, where we compared the 22 and a 25 gauge FNA needle. So 352 patients with pancreatic masses got randomized equally to 4 groups. And the study findings are quite straightforward. So if you have got a pathologist in the room and you can perform rapid on-site evaluation, then it really doesn't matter which technique you use. You have a diagnostic accuracy in the room with a pathologist of more than 95%. If you use a 22 gauge needle with suction, you may run into some problems. The specimen can be a little bloody, and when that happens, it can be difficult to make a diagnosis. But otherwise, your outcomes are superior. Unfortunately, if you don't have a pathologist in the room and then you put all your specimens into your container and you send it out for processing elsewhere, then the diagnosis in your cell block becomes significantly less. What you will see is that your diagnostic cell block is only about 53 to 62%, which is very, very minimal. And in about 45 to 50% of the percentage of the time, you don't have enough tissue to make a diagnosis. So this is the problem with FNA. You have a pathologist in the room, you've got a fantastic outcome. If you don't have a pathologist in the room, and if you're going to rely completely on cell block, then close to 40% of the time, unfortunately, you may not have a diagnosis. Second is cell block is very important for conducting ancillary studies. So if somebody's got a breast cancer and there's a mass in the pancreas, Rose will tell you whether it is cancer or not. But then to differentiate a metastatic breast cancer from a pancreatic cancer, you have to do some special staining and conduct other studies. For that, you need good specimen in the cell block to do appropriate staining. So if you don't have a good cell block, which you don't with FNA, then you've got a problem conducting additional testing. Thirdly, these days, cancer treatment is getting very personalized. So your treatment is going to be based on your DNA and RNA profile. So to get adequate comprehensive molecular profiling, it's not enough to just have tumor material. For some tumors, you also need fibrosis or tissue to perform a good molecular profiling. With a FNA needle, you get a fantastic cytological aspirate or tumor material, but you don't get fibrosis or stroma to conduct adequate studies. And finally, when you are looking at an FNA specimen, you need a cytopathologist. But if you're looking at a histological specimen, anybody who's a pathologist can make an interpretation without a problem. So if you're relying completely on FNA, then you need your good pathologist who can render a diagnosis with a fair degree of competency. So because of these 4 problems, histology needles have been now introduced in the market. There are 4 different types of needles. One is the first needle, Proco from Cook Industry. The second is a SharkCore needle from Medtronic. The third is the Acquire or the Francine needle from Boston Scientific. And finally, you've got the Easy Shot 3 or the Mingini tip needle from Olympus. So now I'm going to show you a video of a EUS-guided fine needle aspiration and a fine needle biopsy in a patient with a pancreatic mass lesion. So this is a 42-year-old male with a mass in the pancreatic tail region with some sort of abdominal discomfort. So you can see that the tail of the pancreas is significantly enlarged, and it's right next to the proximal stomach. So here we are doing an EUS examination, and very readily just below the G junction, you see the pancreatic mass. When you torque your scope anti-clockwise, you look at the liver, and then you see multiple metastatic lesions. So what you're having primarily is a pancreatic mass and some lesions in the liver. So now I'm trying to do a sampling of this mass. So what we are doing is putting a 22 gauge needle into different quadrants of the mass to get a tissue. So this is FNA. So when you perform FNA, this is very classic. You will get some material that is a little bloody. It also has your aspirate in it. So when you look carefully under a white light, you will find some glistening material. The excess material in the needle is expressed onto cytolite. You can see it floating inside. And then now, in the same patient, we are going to do a fine needle biopsy. So this is a 22 gauge biopsy needle being used to sample the mass. So once again, using the same technique of fanning, you pass the needle into the mass multiple times. But you can look at the change in the type of specimen that is being procured. This is more like a gelatinous material. There's less blood in it. And here you don't smear the slide. What you do is you do something called touch prep. You take the specimen and you just move it across the slide using some tweezers. And you can see some material. And then you put the additional specimen either into formalin or into cytolite, whatever your institutional preferences. And then when you process the specimen, you can see on the left is FNA, on the right is FNB. FNB is diagnostic on pass 1, whereas FNA is not diagnostic but suspicious with a lot of atypical cells. So this is the advantage of FNB. You get a profusely cellular specimen right there on the very first pass compared to FNA, where you may have to make 2 or 3 passes to establish a diagnosis. Now, when you look at cell block once more, FNA is suspicious. You got all the blue is cancer material. With FNB, it's profusely malignant because it's a biopsy sample, and this is a diagnosis of the neuroendocrine tumor of the pancreas. So I've shown you the example, the differences between a FNA and a FNB sample. But how do you evaluate FNB sample? I can show you all these pictures, but how do you know this is true histology? And how does this translate clinically into something that will be relevant to the daily practice of tissue acquisition? So we conducted a randomized trial comparing the FNA and the FNB needle, and we were looking for true histology. So 46 patients were randomized by sequence to either undergo an FNA first or a FNB first. And this is what the digital analysis showed us. When you're using a FNB needle, the tissue volume you can see is almost 30 times higher. The tumor volume, likewise, is significantly higher with the FNB needle compared to FNA. And the amount of fibrosis is 4 times higher with the FNB needle compared to close to 0 with the FNA needle. Clinically, in our practice, all of our patients expect us to render a diagnosis on site. So with rapid on-site evaluation, it doesn't matter which needle you use, your pathologist is going to give you a diagnosis as long as you keep performing passes. So what we found is that with a pathologist in the room, with a FNB needle, you make a diagnosis close to 100% of the time. Likewise, the operating characteristic is quite high for a FNA needle. The number of passes required to make a diagnosis with pathologist in the room is literally just a single pass, and you can get a diagnosis if your specimen is cellular. But most importantly, cell block. When you send the specimen out to the lab off-site and you blind them to the information that was acquired on-site, you will find that the diagnostic cell block is close to 98% with the FNB needle, compared to only 81 or 82% with the FNA needle. So this is significantly superior with the FNB needles compared to FNA. And this is very relevant to centers that don't have your on-site pathologist to render diagnosis. So this was done under a clinical trial. So we went back to look at all our data on all the patients we have done over a 3-year period from 2014 to 2018. So when you're looking purely at a rapid on-site evaluation, we wanted to compare the number of passes. And this is not cystic lesions, but only solid lesions. And what you will find is that when we use a FNA needle, you require approximately 2 to 3 passes or 2.5 passes to make an on-site diagnosis. Whereas with the FNB needle, in close to 1 pass, you will get a diagnosis in a majority of patients. The cell block yield is very telling. With a FNA needle, you get a diagnosis about 55 to 65% of the time. If you perform additional passes, maybe you can push it to 70. Whereas with the FNB needle, you can get a diagnosis easily in about 90% of the time on all solid mass lesions, whether it is a lymph node, a subepithelial mass, or a pancreatic lesion, it really doesn't matter. You should be able to make a diagnosis without any problem. And then this is the diagnostic adequacy on rows. We wanted to examine this per lesion. So when you look at all lesions, and then whether it is pancreatic biliary, lymph node, or subepithelial, you will find for rapid onset evaluation, there is really no difference. You will get an equal performance, whether it is FNA or FNB. However, the difference is this. For all lesions, whether it is pancreatic biliary, lymph node, subepithelial, or other masses, such as a gallbladder and so forth, with a FNB needle, you get a diagnosis on a single pass, whereas you may need 2 or more median passes when using a FNA needle. And this is clinically very relevant. So FNB needle gives you a rapid onset evaluation diagnosis with fewer passes compared to FNA. Cell block. So when you compare the FNB and the FNA needle, once more, what you will find that for all lesions, your diagnostic adequacy is close to 93% with the FNB compared to only 70% for FNA. This is true for pancreatic lesions, lymph nodes, subepithelial masses, and all other lesions put together, such as the liver or the gallbladder. For those of you who did FNAs like me before the evolution of the FNB needle, if you don't have a diagnosis in the room, very rarely will you have a diagnosis on cell block. And that was as low as 17%. But what you find here is, even if you don't make a diagnosis in the room with a pathologist, and you send the specimen on cell block, 70% of the time, when you don't have a diagnosis in the room, you will be able to make a diagnosis off-site using cell block 70% of the time. So this is why FNB needle is clinically very, very relevant for all centers that don't have access to rapid on-site evaluation. And this information is critically important. So this was the title of our original article, where we said that for solid mass lesions, FNA probably is redundant these days. FNB is the way to go. And there's a complete change in tissue acquisition where things have moved from cytology once again back to histology. Is FNA relevant anymore? I think it is relevant. The 19 and the 22 gauge FNA needle still should be used for aspirating cysts. In my practice, if you have a cyst more than 2 centimeters, in the interest of efficiency, we use a 19 gauge needle. If the cyst is smaller than 2 centimeters, then we use a 22 gauge needle. If somebody has got coagulopathy and there's been on aspirin or Plavix for a long time, you can't stop these medications because of cardiac issues, and the patient requires a tissue diagnosis, then we recommend 25 gauge FNA needle. And if that is not possible, a 22 gauge needle. If somebody is on aspirin and Plavix, and this just cannot be stopped, and if you have to sample an organ such as the liver, then my advice is use a 25 gauge FNA needle. Given the thin caliber, bleeding is very, very rarely a problem. And we use this all the time when we don't have a cardiac clearance for our patients. So now I hope I have convinced you that for sampling solid masses, FNB, there's enough data to support the use of FNB needles exclusively for these patients. Now the question is, we've got 4 needles on the market. Which needle will give you a very cellular sample that will be good for conducting all sorts of ancillary and molecular studies? Which needle will give you a diagnostic adequacy and accuracy that is going to exceed 90%? Which needle will obviate the need for having a pathologist in the room? And finally, you don't want any fanciful specimen collection method. You want to put everything into formalin so that you can just send it out like you're biopsying an esophageal or a colonic specimen, and you will be rendered a diagnosis with a high degree of accuracy. And if there is a needle that can meet all these 4 thresholds, then I think that will be the most desirable needle for performing fine needle biopsy. And what would be even more fun is when you're looking at an esophageal cancer or a colon cancer, and when you perform biopsies and you take a jumbo biopsy, more than 90% of the time, we get a diagnosis on a single biopsy. Can we do the same for FNB? We now perform multiple biopsies. So in a single pass, you meet all the 4 criteria that I listed. And if you can make a diagnosis on one single pass, then I think this would be what I call the dream FNB needle. Secondly, as I told you earlier, there are multiple ways by which we can get tissue. You can use suction. You don't have to use suction. And some people use what is called the stylet retraction technique, where when you do your FNA, somebody keeps retracting the stylet very slowly and it causes negative suction. So is that one technique that is particularly suited for one FNB needle so that we can achieve the desired goal of more than 90% diagnostic adequacy and accuracy on a single pass in a majority of our patients? So we conducted a randomized trial. The primary objective of the study was cellularity. Which needle will give you the most number of cells, which means tumor cells or benign cells with fibrous tissue, a complete sample on one single pass. The secondary objective of the study was which needle will give you the highest diagnostic adequacy and accuracy on a single pass. And we also wanted to match the best sampling technique for each commercially available FNB needle, and there are 4 needles in the market. Finally, we also wanted to look at what is the role of formalin. If you can put them all in formalin, is formalin ideally suited for a particular needle, and is it not suited for any other needle? So we took about 129 patients and randomized them to 4 needles. The Francine, the fork tip, the Mengini tip needle, and the reverse bevel or the Procore needle. Once the people were randomized to one of these 4 needles, then each FNA biopsy pass was randomized to 3 sampling techniques. Either you use suction, you don't use suction, or you use stylet retraction. So it's a double randomization study. And all these patients had pancreatic masses. And we wanted to, once again, look at operating characteristics and cellularity, which was the primary outcome. So if you look at the Francine needle or the Acquire needle, the diagnostic accuracy for the 32 patients was 100%. The cellularity was 30.9%, and the median cellularity, which is the presence of core tissue in the entire sample, was 73%, which is very high. When you look at the fork tip needle, once again, we achieved a diagnostic adequacy of 100%, very similar to the Francine needle. If you look at cellularity, once again, we achieved a mean threshold of 30%, but most importantly, when you look at median cellularity, sometimes it could be as high as 95% when you use no suction, and 55.5% with a stylet retraction technique. So in essence, for the fork tip needle or the SharkCore needle, if you don't use suction or if you use stylet retraction, you get the best cellularity with an adequacy of 100%. For the Francine or the Acquire needle, stylet retraction is the best technique. You get the highest cellularity of 73% and an adequacy of 100%. And all this can be achieved with just one single pass. If you're looking at the Procore or the reverse bevel needle, suction is the best technique. But even if you use suction, the problem is your cellularity is going to be only about 30%. And the median cellularity can be as low as 9 to 22% compared to 35, 55, and as high as 95% for the fork tip and the Francine needles. So the cellularity is low and the diagnostic adequacy reaches only 85%. So 15% of the time, you may not get a diagnosis. You will not get an adequate sample. For the Mengini tip needle or the Olympus Easy Shock needle, you get a diagnosis close to 100% of the time, but your cellularity, once again, like the Procore or the reverse bevel needle, is low. It's anywhere between 8 to 23%. For your take-home message, unlike the Francine needle and unlike the fork tip needle, when you use Mengele tip or reverse bevel needle, you have to use suction because these needles behave more like cytology needles and not histology needles. So you have to use suction to draw a large number of material into the lumen of the needle. And secondly, given the low yield and diagnostic adequacy, I don't think you will get a satisfactory answer on a single pass. If you use these two needles, the reverse bevel and the Mengele tip needle, and if you're going to depend on cell block for your diagnosis, you must perform a minimum of 3 passes so that you will reach your threshold of more than 90%. So once more, suction should be used for the reverse bevel and the Mengele tip needle, and a minimum of 3 passes should be performed to achieve your goal of diagnostic adequacy exceeding 90%. So this table summarizes everything. To get the most optimal sample, which means to get the best cellularity, the best diagnostic accuracy, and the best overall outcome, for reverse bevel and Mengele tip, please use suction. For the Francine and fork tip, you can use stylet retraction technique. And particularly for the fork tip needle, I think for good cellularity, no suction also is a very good option. So we talked about cellularity, and then we talked about the cell block diagnostic adequacy. Which needle gives you the best operating characteristic or overall diagnosis? So when you're looking at diagnostic sensitivity, the Francine and the fork tip needle is greater than 90%, especially for the fork tip. If you look, although not statistically significant, it can be as high as more than 95% for a single pass. When you're looking at diagnostic accuracy, once again, the fork tip and the Francine needle perform exceedingly well, more than 90%, and as more than 95% for the fork tip needle, which is significantly superior for these two needles compared to the reverse bevel and Mengele tip needle that have an operating characteristic only between 60 to 75%, both for diagnostic sensitivity and accuracy. So this data is very important. A single pass using stylet retraction in patients with pancreatic masses, and likely for every other lesion. When you use fork tip and Francine, you have a sensitivity and accuracy of more than 90 or even sometimes up to 95%. So this is digital analysis. So once more, this is the Francine needle, a very cellular samplet rows. And when you use the special software, the green represents cancer cells. This is cell block material. All the red is cancer and the green is cancer. And you can see very little blood, which is denoted blue. And very similar outcome can be achieved using the fork tip or the SharkCore needle, a very highly cellular specimen at rows, a very diagnostic cell block, and once more, your digital analysis shows a lot of tissue, diagnostic tissue, which is green, and the blue is blood. But when you use the Mengele tip needle, the specimen gets sparse, but it's still diagnostic on rows, and a majority is of the tissue here is blood, but still you have enough diagnostic material, which is green on digital analysis and also on your cell block. And finally, when you use fork tip, it's a suspicious sample. There are atypical cells, but not enough to call it cancer on pass form. Your cell block is very low in yield. And once more here, on your digital analysis, this is all the cancer material that you're getting in green. And then your blue is blood, and the specimen once more is very, very sparsely cellular. So this gives you a good representation of a rows, cell block, and digital special basic software analysis where you split the compartments into different tissue into different compartments, and it tells you the differences between all 4 needles. So this is our graphical abstract that tells you for cellularity and accuracy, the fork tip and the Francine needle perform equally well. And followed by the other 2 needles, namely the Mengele tip and then finally the SharkCore needle in terms of cellularity and accuracy. So this is a very interesting case that we just performed a few days back. Why is a SharkCore needle most optimal for sampling small lesions? So this was a patient who was referred to me last week, and the patient was sent because of abdominal pain. The CT was normal. And then when I did EUS, I found the lesion somewhere in the neck of the pancreas from the stomach. It's very small. The pancreatic duct is not dilated. It's about 5 millimeters in size. And this patient is fairly young, and you have to make a diagnosis. So now I magnified the screen. And after I magnify the screen, I am putting that, I am puncturing that needle using a different type of a biopsy needle. And it just will not puncture the lesion. It kept recoiling over and over. Then I used the fork tip needle, and you can see how beautiful the needle went inside. So let's look at this one more time. So once again, unsuccessful with some other biopsy needle, and then once you switch to the fork tip, it just goes straight in. So one of the way to sample small lesions is don't use magnification when you go in, but as soon as you go in, then you can magnify your screen like what I did here, so that you can see the needle fanning into the mass in different directions. So this was a very, very small lesion. And the SharkCore needle, because of the design, which is fairly a two-pronged needle, can puncture any lesion. And this was clearly a neuroendocrine tumor on PAS1, subsequently confirmed on a cell block. Also, although we have talked different things about needles, don't forget the basics. Fanning is critically important. I would say it's even more important than the type of needle that you use. So this is a 68-year-old patient who was referred to us with a pancreatic uncinnered mass. And here you can see the big mass that's about 2.5 to 3.5 centimeters. And here you see me using the fanning technique using the fork tip needle. Once I have hooked the needle to my near echo endoscope, this is the 4 directions in which I want to pass the needle. I use something called the 4x4 technique, where I go into each direction in the mass 4 different times. I move the needle to the tip of the mass, but I never come out of the mass, so that I'm not contaminating the needle hub with the GI tissue. So you go through all 4 areas times 4. And if you do this, what happens is that you get very, very good representative material from the mass. And there's a nice piece of core tissue, right? You spread it across the needle, and then you put everything else into formalin, and then it glistens very well. See that? And you get profuse amount of material, even without suction with these biopsy needles. And you can see the quantity of tissue that is present there. And when you perform your analysis, as you can see very, very clearly, this is an adenocarcinoma that is richly cellular. So this is my request to you, always fan. And in a randomized trial, we have once again shown for sampling, we compared the standard technique where you just go in the same direction and the fanning technique. And you can see that in a median of 1 pass, you can make a diagnosis with both. But when you look at the ranges, the fanning technique will get you a diagnosis with a pathologist in the room 85% of the time on the very first pass, and then only about 60% of the time on the first pass using a FNA needle. But I think if you perform multiple passes, then it really doesn't matter which technique you use. Your pathologist is going to make a diagnosis before the procedure is completed. Specimen, we talked a lot about the type of needle and the technique. How about you processing the specimen? So my recommendation to you for a FNB needle, you don't have to do anything fanciful. Use 10% formalin. Please don't use 100% formalin. It really, really will preclude molecular analysis at a later time. It gets very difficult. Always use 10% formalin and send it to the lab. You will have a diagnosis like you will have with any histology specimen. If you are using a FNA sample, then I think the specimen is mostly like an aspirate. You want to get good tissue. So histology may not work. You must use a cytolite. And as I've told you earlier, when you use a FNA sample or a FNA needle, you have to perform multiple passes. You can't perform a single pass and hope you're going to have a histological diagnosis or a definitive diagnosis. You have to perform 3 passes. If you're sampling a lymph node, and if you're going to suspect a lymphoma, then I think you have to use RPMI, Roswell Park medium. And this is very, very important because to do flow cytometry and other things, this carrier medium is important. If you use anything else, then I think your flow cytometry is going to be unsuccessful. So what are the best practices in tissue acquisition in 2020? I think you should use a 22 gauge FNB needle exclusively, if possible. You have to fan the needle in different quadrants of the mass. When you use, my recommendation to you, if you are using a biopsy needle, is to use the fork tip or the Francine tip needles, because this gives you good histology. And when you get that tissue, please put it in formalin. and it should be 10%. And if you do all those three things, follow those four criteria that are listed here, and if you follow the outline that was given out in this lecture, then I can fairly assure you that you will be able to make a diagnosis greater than 90% of the time, with the specimen being highly cellular, and also giving you a high rate of diagnostic and adequacy and accuracy in greater than 90% of your procedures with just one single pass. So to conclude, the F&B needles, particularly Francine and fork tip, are most optimal for tissue acquisition, as they yield highly cellular, diagnostically adequate and accurate samples on a single pass in greater than 90% of the procedures, and they also obviate the need for rapid on-site evaluation. So this is my final slide, and now I'm willing to I'm going to look at your chat box to see if you've got any questions. So before I will conclude on the session, probably in another 5-10 minutes, there is about 25 minutes of educational material that my colleague Dr. Bang has put on. So just, this is not commercial, just sit through it. She has summarized some very relevant abstracts from DDW for this morning webinar. She's got some beautiful videos of procedures and so forth. And then at 8 o'clock, we will watch live demonstrations. My colleague Robert Haas will show the RFA of a Barrett's dysplasia. And then I'm going to show you a procedure with fine needle biopsy, hopefully a single pass in a patient with a metal stent. It's a challenging procedure. And then we will perform fiducial placements on that patient. And then eventually we will transition to Winthrop Hospital in New York, where we have Dr. Stavropoulos demonstrating the Prodigy device for tissue retraction in ESD. So let us see if you guys have any questions. I haven't seen anything. I haven't seen any questions. Does anybody have any questions? Everyone on the meeting. All right, I see one. What if we use Cytolite with the F&B needle? Sure, you can use Cytolite with the F&B needle. There's no problem. It's a little expensive compared to formalin. But if you want good cellularity, and also if you move in Cytolite, you have to be in a hurry. So for example, if you're doing a procedure on a Friday evening, and if you put it on Cytolite, the chances of this staying on until Monday is difficult. It has to go to the lab and so forth. 10% formalin, not a problem. You put it on, it's going to stay there for quite a while. Which F&B needle is best for gastric submucosal lesion? Well, I would suggest both Francine and fork tip are both good, but there are a couple of things with F&B. Puncture the mass, big knob down, have your specimen, hold the scope tight against the mouth of the patient so that it doesn't recoil. Use suction continuously. Go to the tip of the mass, one puncture. I think you'll be pretty good. For your stylet technique, do you pull the stylet slowly or remove it once in the lesion? I've seen slow pull with SharkCore versus removing the stylet with Acquire and connecting the suction syringe and using again, evidence tells you, don't use anything. No suction, no stylet, nothing. Just no suction is good enough. But for Francine and fork tip, I think if you really want to go by evidence from a randomized trial, you puncture, and then you slowly tell your technician to retract the stylet as you move the needle within the mass. Do not use suction. Mangani tip and the reverse bevel needle, use suction. That's how you're going to get your tissue. Regarding the characteristic of the various needles used, what would you attribute to better performance? I think, to be honest with you, is the needle design. I think the tip of the needle is what matters. The geometry, I think, between the fork tip and the Francine are constructed different from the other two commercial needles, and that is the reason you get better tissue. So it's purely related to geometry. Any study on stylet retraction versus no stylet? I think we have, this is from Pankaj Desai in India. So this very clearly tells you, Pankaj, on this randomized trial, stylet retraction and no stylet. Yeah, there's a study from Japan that compared, but using F&A needle, not F&B needle, but they said that the stylet retraction technique yields more good histology. I think they use both 25 and 22 gauge needles. It gives more histology compared to your 22 gauge F&A compared to not using stylet retraction, but this was F&A needle, not F&B. And then this is one more. If no rows, how many passes do you recommend if using F&B Acquire? Good. So in my unit, although I say one, if you're not using rows, please perform 2 to 3 passes. You're guaranteed. The only time you will not get a diagnosis is sampling error. A mass in the setting of chronic pancreatitis, you don't see the mass and you're biopsying all around the place. That's when you land into a problem. If you're really in the mass, theoretically, one pass 90%, but 90% is not good enough. To reach 95%, 2 to 3 passes. Do we understand that you recommend different gauge needles per cyst and solid masses and reduce them in case of cigar problems? I don't know what a cigar problem is. So, different gauge. Yeah, for a cyst lesion, be very careful. Solid lesion, 22 gauge. Cyst lesion, more than 2 centimeter, 19. Less than 2, 22 gauge FNA. Always a FNA needle. But if you find a big mass within the cyst lesion, don't worry about it. Go with a FNB needle. As long as the mass is big in a cyst. If the mass is very small, my recommendation is go with through the needle biopsy forceps or the Moray forceps. Other option, you can use a 19 gauge needle and also use a spike bite forceps. It goes through the hub of the needle to get tissue from the wall, from the thick wall. But if you've got a mural nodule and so on, use a 22 gauge FNA needle. Don't use 19 gauge needle, particularly in branch duct IPMN. In branch duct IPMN, if you use FNB needle or a large caliber 19 gauge needle, the risk of post-procedure pancreatitis is 10.5%. So stick to FNB needles for small mural nodules. Suction was better to 4 to compensate. This is from Professor Ken Chang. He's asking us a question. Great talk. Any thoughts on why suction was better for fork tip and stylet retraction better for Francine needle? So Ken, I think I may have misspoken. For the fork tip needle, the best was no suction. If you don't use no suction, it gave the best cellularity, 96%. When you use stylet retraction, I think it was 55.5%. As far as the Francine needle was concerned, the stylet retraction technique worked better than the other techniques. I really don't have an understanding. I don't know whether it has got to do with the needle geometry. Also, one limitation you can tell is sample size. Although it's a randomized trial with 128 patients in the cohort, there were only 32 in each group. So even small variations in cellularity can make a change. But at least for both needles, stylet retraction appeared to give an optimal cellularity and the best diagnostic adequacy. But no suction works the best for the fork tip needle. How to perform FNB needles in the back. How to perform FNB? Okay, this is a good one. In the presence of autoimmune pancreatitis and chronic pancreatitis forming mass. So the most important thing for you is this. Autoimmune pancreatitis, very rarely you will find duct dilation. The duct is just uniformly thin. Make sure you don't puncture the duct with a core biopsy needle. It's a big problem. So what I do is I never use a 19 gauge needle. I do liver biopsies with a 19 gauge core biopsy, but I use only a 22 gauge core biopsy for autoimmune pancreatitis or suspected chronic pancreatitis. Also, so to avoid transection of the pancreatic duct, you want to stay in the lesion. So if your mass is deep beyond the pancreatic duct, then you've got a major problem. So what I will do is I will recommend that you go to the head of the pancreas, because on the head of the pancreas, you remember when you come down and you move into the stomach, there's a neck region. You've got this huge swath of pancreatic head region with no pancreatic duct on the lateral margin to the duodenal wall. There you can put your needle back and forth, and you can do fanning, and you can do anything, and you'll get a large chunk of tissue. So my preferred area is pancreatic head, 22 gauge FNB needle, where there is less chance of traversing the pancreatic duct. Do you have a preference of needle for liver biopsy? I just answered. 19 gauge FNB needle for liver biopsy. Don't use fanning. Make sure you don't have vessels. There have been 3 deaths to my knowledge. I was asked to, as an expert witness for 2 lawsuits. So this is serious business because patients died. So for liver biopsy, no fanning, unidirection, use Doppler very carefully, go 4 times, that's it. And then look at the specimen. You got a good specimen, macroscopically, stop the procedure. If you don't get anything, then you can do a second pass. Don't do stylet. FNB of lymph node, number of passes. I think studies have shown for lymph nodes from FNA literature, if you use suction, you got a problem, you got a lot of blood. For lymph node, no different. Maybe 2 passes is good enough. Coagulation problems, again, as I've told you earlier, F&B needles, I never use, if somebody is on aspirin, Plavix, high coagulopathy patients, I just use FNA needles, and I perform 20, and I use a 25 gauge needle if possible. So that's this question, right lobe or the left lobe for liver biopsy? I think if you're looking at just something like a fatty liver or a cirrhosis, just go with the left lobe or go with the right lobe. I think it really doesn't matter. It matters only if you're sampling solid mass lesions. A choice of needle for pancreatic cyst lesions. Once again, I have told you earlier, if it is a unilocular cyst, a lot of fluid, you can go with a 19 gauge needle. Branch duct IPMN, once again, be careful with the 19 gauge needle, particularly FNB. It's a snake. It causes very bad pancreatitis. I will just use a 22 gauge FNA needle if possible, and if the cyst is less than 2 centimeters. If it's a big mucinous cyst in the tail of the pancreas, 3.5, 4 centimeters, then no problem. Give antibiotics and just use your FNA, your 19 gauge FNA needle. You might be just fine. And I think, moving. So somebody's asking for a SharkCore needle sheath in place. I personally don't leave the sheath in place. I just remove the needle assembly with every single pass. That is my way of doing. But if you are worried about a small mass, you can leave the sheath in place, use suction, be tight, lock your up knob down so that you're not moving away, and you can just change the needles into the sheath at different times. So 22 gauge, would 20 gauge needle be better for specimen and diagnosing lymphoma? I personally think a 19 or a 20 gauge needle is pretty big for sampling a lymph node. I think if you're looking at a very big lymph node of 4 centimeters, there's a lot of necrosis. Maybe there's an advantage. My own personal opinion, I really don't use 19 or 20 gauge needles for sampling any lesion anymore. I just use a 22 gauge needle with the exception of a liver biopsy. So I think we have covered a lot this morning with this topic. So I'm going to end here. We have, there's about 15 minutes of some educational material that is going to flow through. Just look at them, and then we will come very soon with the live demonstrations at 8 o'clock. And I think for those of you in the West Coast, like Professor Ken Chang, who I think wakes up at 3 a.m., he needs to go back to sleep. Sometimes you shouldn't work this hard. Thank you, and I will see you on the live demo very, very soon. And my thanks again to Medtronic for sponsoring this session. Thank you.